Afternoon and welcome to Cambia Grove. We're getting started in 2 minutes, so if you'd like to grab a snack and something to drink and find your seats, we will get started. Afternoon. Good afternoon. Welcome to Cambia Grove. Good afternoon. My name's Jessica Hoffler. I'm the manager of programs and operations here at Cambia Grove. Welcome. This is the 5 Points Provider panel. It is part 4 of 5 in our series that's breaking down the sectors of the healthcare system: the patient, payer, policymaker, provider, and purchaser. We're really excited about the panel that we have today. And without further ado, I'm just going to kick it right off and hand the mic over to Gabe, our entrepreneur moderator.
Thanks, Jessica. Hi, everybody. I'm Gabe Richman, founder and CEO of Omic. We're a precision medicine software company focused on genomics, and we enable healthcare providers to make use of genomics and other complex molecular data in everyday medical care. So I'm going to introduce our esteemed panelists in just a minute here, but first I want to start by just talking to the audience. Who here works in a startup? Raise your hand. Great, lots of entrepreneurs today. Who works in the healthcare system? A few. Who's worked as a clinician or other healthcare administrator? And a handful too. And then finally, who works to support the startup community? Everybody, right? Good. So today we have a packed agenda. Hopefully we'll make it through all of it here. We're going to start by reviewing the role of the healthcare provider as part of the innovation community, and specifically highlighting any impactful innovations that the panelists have seen. Then we're going to talk about presenting the industry trends and barriers to get to those innovations within the novel industry trends. And finally, we're going to discuss some real high priority needs. So the entrepreneurs in the audience will be able to see what is challenging providers today. And I just want to pause and have everybody take out your devices now. And do you see that link at the bottom, pollev.com? That is our poll everywhere. So that's how we'll be asking questions today. And not only can you use that to ask questions, you can also go there and vote on your favorite questions. So those are the ones that we'll be asking. You don't have to sign up for any sort of a link, so grab your iPhone, Apple Newton, Palm Pilot, whatever you use, and go to Poll Everywhere. So with that, I think we'll get started on the provider perspective. So we have Blair, Teresa, Cheryl, and Marc with us, and we'll just get started with a little introduction, and then what the role of the provider is in healthcare innovation.
So my name is Blair Washington. I'm a physician. I'm a urogynecologist or pelvic floor reconstructive surgeon. But I also work in health technology. So I'm really excited to be here today because it blends my two loves. I think the role of the physician in healthcare is that of an advocate for the patient perspective. And specifically, I think my role is to think about solutions that really advance health delivery to the patient. I think oftentimes providers are not involved in consulting on decisions in when technology solutions are being developed, and consequently I think there are a lot of solutions being developed for problems or pain points that may not exist in clinical practice. In addition to that, I would say there are a lot of technologies that are developed for sort of the business of medicine as opposed to the actual delivery of healthcare. So there are lots of, I attended South by Southwest 2 years ago, and I would say 90% of the healthcare technologies that were presented there had to do with optimization of billing, machine learning for regulatory compliance, these types of things. And while those things are important, I really see my role as a physician in technology really thinking about how we move the needle on actual delivery of healthcare. Some innovations specifically from my area of specialty, I'd say, by and large, have to do with device creation. So in my individual practice, I would say laparoscopic surgery was a huge innovation. Laparoscopic surgery was developed in 1911 by a gynecologist at Hopkins. After World War II, fiber optics were added, and the technology has just boomed since then. There are instruments, laparoscopic instruments, lighting devices, ports to enter the abdomen, et cetera, that have really changed the way that we can operate. And I would say most recently in my practice, the advent of robotic surgery has really changed the sort of landscape for how laparoscopic surgery can be delivered. Robotic surgery allows for 3D visualization. So laparoscopic surgery is a 2D visualization of the patient abdomen. Robotic surgery allows for 3D visualization. It's almost like you're floating inside the patient's abdomen when you're operating. It also allows for articulation like a wrist. So in laparoscopic surgery, your planes of movement are, planar. I don't know what that is. But with robotic surgery, you have 3D articulation. And so it really made surgeries that were very hard to perform laparoscopically much easier and hopefully decreased postoperative morbidity through small incisions. I think I have one more minute because I want to mention one other company. It's a Seattle-based company called MD Metrics. So I've talked about some device advents. There's also a company that I'm really excited about called MD Metrics, which is a software company that is being incubated out of Children's. And basically what they've done is they've figured out how to use EHR real-time data to answer real-time clinical decisions. And so they can query their database and answer a question in a matter of seconds that historically would take us maybe 6 months through literature review and analytics to answer. So anyway, those are my current health innovations that I'm excited about.
Hi, my name's Cheryl. I am a primary care provider. So my first innovation is learning how to use the microphone here. So I've been a primary care provider, trained in Seattle, and so primary care for about 25 years. I would say innovation has been sort of a part of my career from the beginning. Primarily in looking at care models, so how do we innovate how we deliver care, and doing it in residency, and then shortly after residency looking at group visits as a way to educate and teach patients how to better take care of themselves and sort of activate them in their own health care. The systems were not quite yet ready for that when I was doing that about 20 years ago. The needle has definitely moved, and I would say right now I am in probably the most innovative care model that allows me to be the best primary care provider I can be by being able to innovate on a daily basis. So there is some technology involved, and I would say it's more of a tool for us to be able to look at our patients in a way that is how the patient experiences healthcare and how we're able to look at populations using marker sets and things like that. But more importantly, I think the innovation is the care model that I'm in, which is a team-based model that's truly a team-based model where everyone in the team, from the operations assistant at the front to the nurse to the health coaches who are in on every visit, are actually being able to innovate in what that patient needs right in the moment for their care. And we'll go into more examples, but being able to do home visits or being able to know when people are in and out of the hospital, those are the things that allow me to innovate. How do we take the best care of this patient with what they need right now where they are, whether it's in our office or outside of our office walls. So that's been actually really super exciting. And I think for me as a primary care provider has allowed me to grow and be better and better at what I do. So the model makes a huge difference in the kind of care we're able to deliver for folks.
I'm Teresa Girolami. I am a board-certified internist. I have a primary care practice in the East Side, and I'm also the current president of the King County Medical Society, which we represent over 2,000 people, 2,000 docs or providers right now, looking for more members. So I have done a couple things in my career. I started here in 1991, but I'm a native Washingtonian. I'm actually from Tacoma. And I started about 5 companies so far, from 0 to selling it, and I have learned massive amounts of information, good and bad, getting the door slammed in my face a few times, and actually fundraising. So it's been a very interesting career there, but all the time I maintained my primary care practice. And for me, in innovations, interesting, one day I was doing paper charts, and 2 days later I was on an EMR, which was very, that was a big learning curve, but I actually went home and did my little web-based tutorial and learned how to do it and have gotten better at it. But for me in primary care, I truly believe in wellness, and I really am a big proponent of diet and exercise and no medications, although I am an internist and they tend to write lots of prescriptions. I tend not to. I try to hope we can be healthy from the get-go. And I really feel my job as a primary care doctor is to help you be healthy, happy, and live the longest life you can, hopefully medication-free. So we try our best, but obviously if you have high blood pressure, I will write you a medication for that. And as far as healthcare innovations in my practice, I actually did a gynae one, which I'll talk to you about later, would be things like keeping the patient out of the ER. So now we can do those respiratory treatments in the office. We can do spot labs in the office. I know what your hemoglobin A1C is, your diabetes levels while you're there. That has been really groundbreaking, and you can do all of that. I built a whole lab in my office because you can do all of those things in office and get the results today. I had a lady in today, she goes, "You got all those results?" I said, "Yes, I had them yesterday. You came in today." So that has been really helpful in keeping people out of the urgent care, keeping them out of the ER, keeping them healthier, I think has been very, very helpful. I'll go into all my little stuff later, but I think that's good for now. Thank you.
Hi, my name is Marc Miller. Appreciate everyone showing up today. So my background as a physician has been, most recently I was Chief Medical Officer of the Polyclinic, which we sold in January. Prior to that, I've been really blessed in my career in medicine, combined with having a wife who's very understanding. So every few years I've had a chance to reinvent myself in a variety of settings, both on the provider and payer side at risk populations, with seniors, fully value-based, and yeah, it's been very, very good. I've learned a lot, made a lot of mistakes, and hopefully it brings some perspective to how I look at opportunities at this point. What's the role of provider in healthcare innovation? I want to take it in a little bit different direction, which is to recognize when we talk about providers, we're talking about much more than physicians, right? We're talking about people, we're talking about nurse practitioners, physician assistants, dietitians, physical therapists. We're talking about everyone. We're talking about pharmacists and retail pharmacies. And we're looking at this, we need to consider their scope of practice, which is changing. It's based, every state has a different scope of practice for all the specialists, but those are really important things to keep in mind as we're talking about innovation, because a lot of the innovation that has to do, and also we're talking about providers who we don't even recognize as providers, healthcare providers, but who really should be. And I'm thinking about social determinants of health and the people who impact that. And if you have a frail senior, for example, and being able to arrange transportation for them to get to their appointment, well, then the Lyft driver's a provider, right? So just to keep that in mind as we think about our definitions. In terms of innovation, I'm going to mention innovation that's always stayed with me, which was the combination of being able to monitor patients at home through Bluetooth-enabled technology and everyday devices like scales and blood pressure, and through that technology being able to alert. We had a practice we were responsible for thousands of patients, fully at value. And through that information from the patient at home, we were able early on, through nurse practitioners, physician assistants, to be able to identify those patients who were starting to move at the very beginning of moving towards problems with congestive heart failure, things like that, blood pressure, diabetes, and able to bring them in and prevent hospitalizations. Not just readmissions, but the initial admissions. And the reason I mention that in particular is it really speaks to the idea that innovation is setting dependent. So that kind of setting I just talked about would not, it just doesn't align as well in a fee-for-service world as in a world where providers have risk. So it's just something to keep in mind, and that's why I bring up that innovation. And I guess that's it.
Thanks, Mark. So I'm going to ask the audience now to go to Poll Anywhere, or Poll Everywhere, I should say, and anywhere and everywhere, and enter your questions. And while you're doing that, then maybe I get to ask the panel a question of my own. So I'm wondering, Mark, in the example you described, or some of the other innovations from large to small, how do you find out about these, and what are the what are the hurdles that you have to overcome to actually bring them into use in your practice or where you've seen providers bring them to use?
Happy to answer this from my perspective. The examples that I gave were huge sort of pivots, I think, for how people operate. And I think people are still in their painful learning curve to understand how to make those transitions. When I started medical school, laparoscopic cholecystectomy was kind of like an interesting alternative. And by the time I finished residency, it was standard of care, and it pushed a lot of people through their learning curves to incorporate those technologies into their practices. And I think we're seeing the same thing right now with the robot. I was fortunate that, just because of how my training was timed, I went through my learning curves while I was in training programs. But I think that, surgeons that have to incorporate really pivotal changes in technology do that through meeting attendance, weekend courses, mentoring programs, but that's a huge area of research and also concern to figure out how you bring people up to proficiency, how do you give people credentialing on new technologies, especially in the operating room, but across the healthcare setting.
And Marc, we actually had a question come in that was relevant to your topic of conversation. So the question is, does the guidance on reimbursement for remote patient monitoring incentivize you to adopt new technologies?
I'd say this, first of all, to get back to adopting technologies. In healthcare, we're so much more conservative in adopting new technology than so many other industries. And now getting to your question, the setting, that's a perfect example of technology fitting the right environment. And, all sorts of different aspects of the environment, but this one in particular talks to financial risk and who's paying for it. So to the extent that you align the technology you're thinking about introducing with the people who are paying for it having that as a pain point, then that lines up. But if it isn't a pain point for them in their reimbursement model, then you're not going to get traction. So I hope that addressed the question. Person had in mind.
I think it does. And then Teresa, you started 5 startups. So how did you ever overcome the barrier that Marc was talking about, where there may not have been a direct payment fit? And if so, how? And did you find a way to benefit the patient anyway?
That's a great question. So the first startup was an obesity management program. And I thought about the payer. So I said, who would be most benefited by having lower healthcare costs in their system? So I went to a very large tech company on the east side in Redmond, Washington, and I did a pilot. And they said, do a pilot, and they were kind enough to pay for the pilot. And so they funded that, which is very unusual. But I had to show data that if people actually lost 5 or 10% of their weight, did their diabetes go down? Did the hypertension go down? Did high cholesterol go down? Did heart disease go down? Asthma, blah, blah, blah. And I could show that. And so then I got that in as a benefit. So then the payer was the company, and they're self-funded. So it was not by the insurance company, who at that time was no-go, that's not a real code, that's not a diagnosis, we're not going to pay anything if you write that ever on your fee slip. So I went around them, and I went to the self-funded companies. They're the ones that were actually paying anyway, and they were going to pay the cost in the end either way, disease state, non-disease state. And then I thought it wasn't incentive enough for the patient to have it completely paid, so I made it an 80-20. And I presented it that way, that the patient had to put 20% of their skin in the game to get the result, and then the company would pay the other 80%. And that benefit exists today in that company, but then we got it through about 8 other companies that were self-funded. So you have to know where the money comes from and who's most incentivized to pay for it.
Great. Cheryl, specifically in primary care, it seems like it's so broad, it would be really difficult to find specific innovations you could actually implement. So in your role, when you're looking at the massive landscape of things you could possibly do, how do you focus, or where do you find sources of innovation?
As far as technology specifically, or just any?
Just any innovation.
Yeah.
I'm going to make it even broader.
Yeah. So I think, directing things at like how to prevent stuff is one of the places where we try and look at ways to innovate. And again, at Iora Primary Care where I work, it's really sort of team-based in the sense that anyone on the team can present stuff where there are pain points, so that we come up with processes or changes that are often not necessarily technology-based, but more sort of systems-based on how we approach, somebody with high blood pressure, managing them at home, or somebody who can't come into the clinic, or somebody leaving a hospital situation or going into an adult family home, using more process-based opportunities, I guess, to move the needle on helping to keep people healthy.
Very good. Thanks. All right. I think it's time to move to the next section. So we're going to talk about now the current industry trends and most importantly, the barriers associated with keeping up with those trends. And so we'll start with Blair, and we're going to talk a little bit about the trends that you've seen and the barriers, and we'll go down each panelist, and we'll have Q&A in between. So don't forget, poll everywhere.
So I'm excited to talk today about advents and opportunities for technology to advance evidence-based medicine. And I think there are a lot of challenges to doing this. Evidence-based medicine essentially is using the highest quality or the strongest medical evidence available to make decisions in individualized patient care. And so one of the challenges is that a provider must do a rigorous review of the literature, which takes a lot of time. And there are actually formal rules that govern how that literature search must be conducted. And after they've done the literature search, then they must know how to interpret the results. And then the information needs to be incorporated at the level of patient care. So providers must have time to do all of that, which is a lot, and they have to integrate a lot of disparate information, maybe conflicting studies or guidelines to make a decision. They have to account for the patient's individual social history, medical history, resources, values in arriving at a decision. And then they need to deliver that to the patient and then move on to the next maybe 30 patients that they have on their panel to be seen that day. So it is a huge rigor to try and incorporate evidence-based medicine into your daily practice with all of the patients that you care for. And as you can imagine, it can be difficult to scale, to use a technology term, to scale that to an entire patient panel. So I think there are a lot of opportunities to use technology to support this. I think immediately developing evidence-based medicine solutions. I work for a company now, and that's essentially what we do. We create evidence-based guidelines to inform healthcare. But the back-end process is really manual at this point. I mean, we are, physicians trained in evidence-based research, culling the literature manually to identify the highest standard of care for a particular outcome and identifying conflicts where those exist. We rely on large studies, systematic review and meta-analysis among other studies, and where there is no evidence or there is a paucity of evidence, then we rely on society guidelines to determine those, to make those decisions. So it's a cumbersome process, and these solutions are necessary, and they need to be at the point of care for patients, or for providers. They essentially don't exist for patients. I think patients are increasingly wanting to be informed consumers. They're part of the healthcare team. They're really an important part of the healthcare team as we think about personalized decision making. But there are very few solutions for them to understand what the up-to-date evidence is for whatever their particular condition is, to ask appropriate questions when they come in for their appointments. So I think direct to patient products are a huge opportunity. In terms of the future, I think leveraging machine learning to achieve these solutions will happen. You know, every diagnosis, management decision, and therapy could be personalized based on an individual patient, and based on all of the known available information that exists in the world. Machine learning would allow the marriage of patient-specific information with population-based data, as well as all of the massive amounts of medical research that's available. I don't know if anybody saw the New England Journal of Medicine article on machine learning that was published last month, but they did a really nice review of machine learning in medicine. You know, machine learning allows the synthesis and analysis of immense amounts of data, as I'm sure most people in this room understand. And in medicine, those big repositories of data exist in the electronic health record, as well as the repositories of medical evidence research. Potential applications for machine learning were really nicely laid out in that New England Journal of Medicine article. They talked about prognosis platforms, probably like Omic, predicting patient health outcomes based on a variety of patterns and predicted trajectories. Other things like cardiovascular risk assessments. They talked about machine learning and workflows. So querying the EHR like you would query Google to say, has this patient had an MI, and allowing that information to come back to you rather than having to cull the electronic record to find it. Biometrics was another area that they talked about. How do we incorporate and apply all of the biometric information that we're currently accumulating with smartphones and digital wearables and all of these things? They talked about using machine learning for billing, automatic prior authorization, these types of technologies. But really what I'm super excited about are the potential opportunities for machine learning for diagnosis. How do we use artificial intelligence and machine learning to review films or interpret pathology or interpret genomics? There are tremendous barriers. You know, I think one of the problems with developing machine learning technologies is that if you put garbage into the system, you're going to get garbage out of the system. So the algorithms need to be based on high-level evidence. There are inherent biases in our medical records that need to be accounted for in order to create useful and broadly applied algorithms. You know, so often in medicine, our diagnoses in our medical records are driven by ICD-9 codes or CPT codes, which actually may not be the patient's diagnosis or problem. And if we base machine learning algorithms on that information, we're going to get inaccurate information out of it. A second barrier is that providers must be a part of the process, in my opinion. We must review and refine the algorithms to make sure that we get appropriate information out. And then we're going to be the ones at the bedside actually applying the information that's delivered, and that has to be understandable and specifically applied. I think maybe the last two big barriers, the one is the electronic health record. It's an advantage and a barrier. Electronic health records are owned by companies. The companies may not be aligned to provide all of this information that we want to cull. Their business models may not drive that type of innovation. And they're full of protected health information, so how do we guard that? And then regulatory. I think a solution that I see is our major move to value-based medicine and pay for performance. I think that those investments will help drive opportunities where, you know, better alignment of financial opportunities, and also regulatory changes that may allow for some of this to occur.
Great. So we had some poll anywhere questions come in while you were talking, and I think the first one relates a lot to the startup that you were talking about, MD Metrics. Now, so when you think about how, as a practical matter, so you think about your role in practicing medicine on a day-to-day basis, has the progress in interoperability actually made a difference in how you perform medicine?
You know, I think one of the challenges is that there's such limited interoperability in medicine. You know, I mean, in my practice, I had a full-time person in my practice who, you know, my practice, I'm a subspecialist. Most of my patients have seen other providers before they get to me. So there's a lot of health information to review. In my practice, almost all of that information came in over fax machine, because even though those patients may have been in systems that had EHRs, even if they had the same EHR platform that I had, our EHRs didn't communicate. You know, maybe in radiology there's some interoperability. I think that's a huge and ongoing struggle.
Absolutely. I would say you also talked about how these literature searches in evidence-based medicine are just really daunting and time-consuming. Is there a point where you just can't create the mental space to do the types of things that you'd like to do? And do you have any sort of top areas where you'd love to see innovation?
I mean, I think everyone practicing medicine worries about this, right? I mean, we all feel like we're the smartest that we will ever be and most up-to-date when we graduate from training, because that's when you have the time to spend to learn everything that you might need to know about a particular topic. And so that's why I think, you know, solutions in this space are so important, because the body of evidence-based medicine is evolving as it should. And we've got to figure out ways that are easy for providers to have access to and to incorporate those changes in their practice. That's beyond going to you know, academic meetings a year or that type of thing, or, you know, finishing your you know, continuing medical education while you're like trying to get your kids to sleep at night, you know.
So if this and I'll open this one up to the broader panel, but if the new world of machine learning opened up and took the place of a lot of your work with evidence-based medicine, where would you focus your additional time beyond putting your kids to bed at the right time? But where would you love to focus your time, but can't right now?
You know, I think that if I think about being in a clinical practice, you know, you're gonna spend your time at the bedside with the patient. You know, it frees you up to be certain you're providing high-level evidence-based care and focusing on the needs of your patients rather than, you know, big literature reviews to make sure that what you are delivering to them is, you know, the right information. I mean, I think a lot of times people practice medicine, they continue to practice medicine that they learned when they were in training as opposed to evolving, and hopefully what this does is it just keeps everyone evolving.
So, Gabe, can I take a shot at that?
Sure.
Unfortunately, my mother smoked her whole life and didn't listen to her daughter, and now has lung cancer. So every other Friday, I'm right over here at Seattle Cancer Care with my mother. And so she's in the Franciscan system in Tacoma. So when she got diagnosed, we went down there. And of course, I did all my research, and I had to get up to date and understand what her options would be. And she's 80 at the time of diagnosis, but relatively healthy, doesn't take any medicine, and played tennis and worked until this moment in her life. So we see the young, and you're much younger than I am, the young oncologist, and I have 4 brothers, and I think 3 of us are there, and I'm listening to everything he's saying about what she should do. He opened the book, he went to the evidence-based medicine, and he just read it right out to her. And I'm looking at her, my mother, and in this treatment that she has small cell lung cancer, you're supposed to irradiate her head so that it doesn't metastasize to her head later in life, and ultimately that would be the end. And I'm looking at him and I go, you are very sweet and young, and I'm sure that's what the book says, but are you looking at my mother? I said, she's 80, she's not 50. She's not gonna be able to take these kinds of very toxic chemotherapy and irradiate her head. I said, but thank you, I know you're right. So I went over to Seattle Cancer Care and I saw an older physician who was much more experienced, and he said, I would never irradiate my mother's head, ever. And I said, nor would I. So, and nor would I do that chemotherapy. So we did a different regime for her. And it's actually my talk's all about that kind of stuff. A different regime for her, and she's living for 4 years, and she should have died in the 6 to 9 months that they all gave her. So, but to his credit, he is on the newer protocols and the newer things that are out there, and she's on immunotherapy. And so, knock on wood, to this year, she's 4 years out. So it's a little different scenario sometimes.
You know, what I would say is that is absolutely true. Care, individualized care matters, right? Like, what matters to a 20-year-old is different than what matters to a 50-year-old. What I think is so exciting about machine learning is that it marries the evidence in the literature with population-based healthcare. So it has the potential to deliver solutions that are where they can look at somebody like your mom in the population and make predictions that aren't based on a study protocol of what the outcome should be, but based on a population of people and what the outcomes were. And we just don't have. I mean, it is beyond the capacity of the amount of data that would have to be analyzed to be able to provide individualized care. Statistical predictions is just beyond our current capability. Yeah.
Well said. All right, so let's move on to Cheryl. So Cheryl, what are some of the industry trends that you're seeing from your perspective with a working mic, we hope, and what are some of the barriers you see to reaching those?
Yeah, so I just wanted to start with a patient story to help sort of illustrate how we are working with folks and what the patient journey looks like. So this is a typical senior patient that we see. His name is Richard. We met him. He's 76 years old, and about 3-4 years before we started working with him, he sort of had a big shift in his life. He had previously been a successful Microsoft software engineer into his, I think, late 60s. And was living independently. He got an unusual problem called Guillain-Barré, which is a progressive neurologic problem that you can recover from. But the recovery took him about 6 months in an intensive care unit on a breathing machine and a year in rehab to get back to any sort of level of functioning. So pretty extreme story. And that left him with some impairment to his cognition that made it so that he wasn't able to work anymore. And also some incontinence of both urine and stool that has some social implications as well as other difficulties. And when we met him, he was good-humored, social. He liked to come and sit and do the puzzle in our community area. And as we got to know him, so getting to know him was really sort of the basis of what drove our care. We discovered that he lived independently, drove, really didn't cook or do any kind of food prep for himself, and actually was out in the community going to different churches or food banks on a scheduled basis. So he had a schedule, and he would see the same folks kind of every Monday he went to one place, every Tuesday he went to another place. So he had no sort of what I would consider normal social supports, no family or friends that he had contact with. But out in the community, he was really interacting on a very regular basis with folks who knew him and could assess, sort of changes or when things were not quite right. By the time we met him, he was starting to have challenges in taking medications. And so we sort of look at our folks and say, we have something called a worry score, which helps us sort of kind of risk stratify, in a sense, our patients. It's not sort of risk stratifying in the context of, is this somebody with a lot of chronic problems that, I guess the context is more of not just medical problems, right? So as we get to be into our 60s, 70s, and 80s, a lot of folks have a lot of medical problems. But it's more the context of that social context as well. So he obviously had some social chaos going on, which made us really worried about his capacity to take care of things. So he was, in our system, a high worry score patient, which means that we have regular touches with him. We have sort of a population-based way to pull up our populations that are managed by our health coaches. So each health coach has a panel, and every week they panel round on them. And all the high worry score people who they haven't touched in the last month come up. And they are able to interact either a phone call, or do we need to get them in for a visit, or sometimes it would be interacting with the folks out in the community who knew Richard to see, have you seen him? How's he doing? If he didn't answer his cell phone, for example. So we have a way to sort of manage that risk. And as we got to know Richard, it became clear that food insecurity was something that was a big issue for him. So, you know, social determinants of health, with him not able to kind of manage his own food sources, and his cognition declined over time. We were able to go in and do home visit with him, you know, as we were contemplating, hey, Richard, your diabetes is worsening. How are you doing with your medications? Well, when we did a home visit, it became quite clear why he was unable to take his medications and why his diabetes is out of control. We went out with our social worker and a health coach. He actually didn't let us into his house, but it was pretty obvious from the outside what was going on. So really dirty, not able to keep things clean. There was, you know, food smells coming out. You couldn't even like physically walk into the house. So insulin really wasn't a thing that we were headed towards. So he couldn't even take his medicines. It became obvious to us that he had no way to take his medicines, let alone check blood sugars, monitor his blood sugars. So we started, you know, as a team, this is how sort of just the wraparound care problem solving with the problems that this patient had in order to try and keep him out of the emergency room, out of the hospital, safe. We started having him come in once a week. He did drive. At a certain point, he didn't drive and would take Uber rides. So coordinating transportation is one of the things that we're able to do to help him. Sorry. And so eventually, just to kind of wrap back around, eventually, you know, he kind of continued to decline. He was coming into our clinic on a weekly basis or bi-weekly basis to get medications. He at some point became homeless. We had to involve APS. He was lost out in the community in, you know, shelters, in and out of the hospital. Our team had consistent contact with him. He is now in an adult family home and has a guardian in his overlooking his care. He has controlled diabetes. He has progressive dementia, but really without sort of this kind of wraparound care with things like high worry score, frequent touches, coming into our clinic with rides or medication management, he really probably would have ended up in real dire straits with who knows what. But he's safe now and able to kind of live out with support the rest of his life. So I hope that sort of illustrates some of the different levels of places where we intervene and are able to have wraparound care with our folks.
Oh, thanks, Cheryl. I love the patient stories. Those are great. To start off, I'm going to try to incorporate as many of these questions, the poll everywhere questions, as I can. But I want to start with your story about Richard. So with such basic needs not being met, I'm wondering how you would like to see more innovation in the area of wraparound care, or where you've seen things maybe that you didn't mention during your story.
I I mean, I think coordination of care is really the core. So, interconnection between technologies and EMRs and things like that is one place. Transition, so people going in and out of hospitals, in and out of emergency rooms, not adult family homes, but SNF units and things like that, those transitions are places where I think we need to innovate better in order to keep people safe. We have a system, because we are a value-based system working, at least in Washington, with only one payer. We do have immediate access to information like who went to the emergency room yesterday, so that we can reach out to them and find out what's going on and what do we need to do to keep them out of the emergency room and safe. We find out who's gotten admitted, and we have a whole system around contacting and coordinating with the hospitals, contacting at those transition points when people come in and out. But at this point, it's manual. It's our team reaching out and having the time to reach out to those places. And I think some of that could be streamlined with interconnected technology, more and better information as people from different payer systems are interacting with either our system or every other system in the city and country.
Sounds like we have some comments from the panel.
Just going to follow up on that because, I totally agree. I mean, those transitions of care when someone leaves the hospital and the provider knowing about it, it's tough enough as it is. And I saw some data that really brought that home, which was that even when you think you have high utilization of hospitals that are in your network, you can be surprised. And the data showed, which was a pretty well-run organization, that 40% of the hospitalizations were occurring out of network. And, just sort of like a whole total blind spot. And by the time you caught up with that, you'd lost a lot of opportunities to really help the patient.
I just wanted to say one other thing. I had that problem where I was not getting notified from the ER. So you can really intervene quickly, right? If they say see the doctor in a day or two, but the hospital's never notified you, so you don't know to contact the patient. So I actually called my local hospitals, and I asked them to send me a one-pager and just tell me that they were there and what they were for. So I get that overnight now. They fax it to me, and then I can see and I can call them in that day. And that, I think, has really helped. But they didn't know that I wanted that note. There's like, well, some doctors don't want it. I go, what? You're referring them back to me. I mean, I need the note. So I totally agree with you. That is just one cog in the wheel that could really be streamlined.
I think, too, the evidence-based component of it, so there is a lot of evidence that within the 30 days of after admission that patients are at risk, and that primary care can really make a difference in decreasing admissions and readmissions. We've got integrated into our own homegrown system some of that evidence. So I think, how can you make the evidence at the point of care? It's integrating it in some realistic way into the EMRs. So we have there's something called a LACE score, which is sort of something that's being used nationally, but it automatically calculates with, and so the folks that we have in the hospital, their LACE score will calculate, and it tells us who is at higher risk for admission. I think it also, you can't just rely on technology. So it's also that relationship and knowing your patients and who are their supports, that we can override that, right? So if somebody has a LACE score, say, of 6, which is not high, and we know they have no social supports, they just recently were homeless, we are going to step in and intervene. So it's that marrying of technology and evidence with sort of knowing people and the relationship component that can't sort of be replaced by technology.
And we had a question about the cost of the people. So certainly you talked about team-based care and how expensive team-based care can be, and taking people out into the community to help. Now, Iora is it sounds like it's value-based care, has adopted value-based care, so that helps. But how do you actually justify the cost? Is it just emergency room visit reductions, or are there other metrics that you also use?
Yeah, there are quite a few. So I mean, some of it is outside referrals. So probably when we look at cost of care, it's not the cost of care in our clinic that's expensive. It's the cost of care outside of our clinic that's expensive. And so it is a challenge, right? People may see us a couple of times a year or have a couple phone contacts in addition to that. And it's how do you manage things outside of your walls so that people are safe and you're reducing cost and redundancy and redundant emergency room visits and things like that. I think that from my experience there, that really the core is people want to be known and seen, and when we have that level of trust with people, they come to us first. They reach out to us. They'll call us from their hospital beds or on the car on the way to the emergency room, that we don't always have to wait for those notifications, because it's our patients who trust us who reach out to us.
That's great. We'll take a quick comment from you, Marc, and then we're going to need to move on.
A real quick comment. So, when you think about the costs of team-based care, you have to really throw a very wide net and look at the soft and hard costs. So I'll give you an example. We don't have a lot of time, but one example is team-based care improves the retention of providers and staff. And losing those providers and staff as a cost can get very expensive very quickly.
I need a minute. I'm writing that down. That was good. Okay, let's move on to Teresa. So let's. Oh, Marc. All right. Thank you. That's right. That's right. Thank you. So, Marc, which is a perfect transition you gave to yourself. So
yeah. And unfortunately, I just wiped out one of my talking points too. So, but anyway, so I'm talking about the future of work, and the way I want to have us think about the future of work is how to meet the expectations of providers going forward. And there's a lot of different trends and thoughts that can go into that. I just want to highlight maybe 3 of them. And I'm sure the rest of the folks here have plenty of other ones. But the ones I want to mention that I think are really important, the first one would be future of work providers is meeting expectations for work-life balance. And where I'm coming at with that one is, so in the last 3 years, interviewed plenty of physicians to make and hire. I hired about 40 of them over the last 3 years, primary care and specialists. And about 90% of those physicians are physicians who are just coming out of practice. So, I'm sorry, just coming out of residency or fellowship. So younger physicians who are, I guess I'm using them as a leading indicator of what the future of work-life balance would be. Of those physicians, regardless of gender, the vast majority of them, way past 50% of them, were looking for work-life balance that previous generations of providers didn't really speak about. And most of them were looking very clearly for part-time positions. So as we think about the future of work, meeting the expectations of providers, and how technology may help that, that's something that's going to become increasingly important. And previously, when people had talked about shortages of providers, I think this factor of people wanting to, and rightfully so, having work-life balance, work part-time, is going to exacerbate that. So that's one of the considerations to think about how you put technology around that. A second one I want to mention has to do with protecting what I'll call the art and science of medicine, that we're not losing the humanism that occurs with the increase in technology. And I know Teresa will be talking about technology, so I don't want to go too far over there, except so. But I do. There was a study that came out I read about in First Healthcare about a week ago, 2 weeks ago, and this doesn't reflect the reality of life for providers in general in practice, but again, maybe a leading indicator of where we're headed with technology. This was looking at how internal medicine interns, first year of residency training, spent their time in a typical 24-hour shift. Okay, so now remember, we're thinking about the art and science of medicine. Of the 24 hours, they spent 3 hours on direct patient care, being with the patient. Okay, which is what we all went to medical school for. 3 hours out of 24 hours. They spent 1.8 8 hours on education, which is good. This is, residencies when you get educated. But of the 24 hours, 15.9 hours was on indirect patient care. And predominantly that was medical recording, with the the EHRs and documentation. So when we talk about the future of medicine, it's protecting the art and science of medicine, protecting the art part. And I'm encouraged in recent discussions I had with two medical school deans, you can see they're really trying to, even though there's this explosion of information to teach medical students, they're really trying to emphasize the humanism part of it. And you see initiatives like something called the Gold Award. The Gold Foundation, they're trying to make it equivalent to AOA. AOA is a medical fraternity for people who are excelling on the science part of medicine. The Gold Award is aimed at those students who exhibit humanistic tendencies. So that, in terms of the future of healthcare, expectations of providers, is something to mention. And then third one, we talked about team-based care. It's sort of a little bit of a paradox. On the one hand, providers through technology may be becoming more independent, but at the same time, we're also seeing there's so much value in team-based care. So the future of healthcare is how do you array technology in supporting team-based care? And perhaps people have others or whatever questions.
Sure. This actually relates to one of the questions from the poll from the group. So I'm going to expand it a little bit. So the question is, how is your organization retaining patient loyalty in a consumer-driven market? And I want to expand it to say, in an era where the consumer-driven market is that we get angry when our Lyfts and Ubers don't pick us up in 30 seconds, how do you retain physician loyalty in a market where consumers have such changed expectations from just a few years ago?
So I just want to make sure I got the question. And then definitely, is it how to retain
both
providers?
patient and then physician loyalty, since you've hired so many physicians over your career?
I'll make a quick comment about a couple comments about retaining patients. It's very interesting to see what previously was the components of concierge medicine now becoming standard required parts of any kind of medical practice in terms of how quickly patients are responded to and how quickly and the various services that are provided to them. It's one part of that, which is also a problem, is that with electronic health records and access to MyChart, you get messages from patients, right? And so it really is, you want to provide good care, so you respond to those messages. Same time, it's sort of, well, it doesn't sort of, it definitely gets into your family life in the evening. And you find that there are patients who are sending messages that are so detailed that clearly they're trying to avoid a visit, which is fine in a value-based world. In a fee-for-service world, it isn't so great. So I sort of danced around your question. I think you just have to continue to improve the services that you provide to patients. So in a prior life, I was in a practice where we had 15,000 seniors that we were fully at risk for, and beyond the medical care we provided in having social workers and pharmacists in the clinic to help them and behavioral health people, we started out offering a variety of other services to create an ability to retain them. So for example, one of the things, and I really loved doing this, was I started a book club for our patients. And it was really interesting. At that time I was a lot younger, and to hear their perspective. But I think more and more those kind of lifestyle arrangements or lifestyle destinations, if that's a fancy way of doing it. Now on the provider side, I mean, the quick answer is things like team-based care, recognizing, doing whatever you can through technology and other ways to create at least some kind of boundaries at the end of the workday, which are really porous at this point, and also using a whole variety of physician extenders both within part of team-based care and beyond that. And I'm sure, all of you have other ideas.
I'm going back to the office to finish all my charts.
Yeah, I mean, what I would add to that, and I don't know, how technology dovetails with it, but skill task alignment is so important in medicine, and I think we are, so much has been put on providers in medicine that doesn't need to be performed by providers. And so if we can skill task align, it can relieve and balance workloads. And then I think the other part of it is, just being present when you're in a patient experience, I think does a lot for building rapport with patients and creating opportunities to, maintain long-term patient relationships.
You just remind me of something, which is, I'm not sure if you guys use scribes or not, but I used to think scribes, scribes are people who are interested in maybe going into medical school or dental school or nurse practitioner school who, for minimum wage, very bright, recent college graduates who will be in the room with you and help record the encounter. I used to think that was like a 10-year industry. And now more and more, I see the younger physicians who I've hired, they're asking for scribes. And that's really improved exactly what you're saying, Blair, about being able to maintain eye contact with the patients and be present for them.
I think one of the skills is learning how to leverage our team. So this is something I've had to learn is just how to pass things off to people. It's not something that we learn to be part of a team when we are in training.
Very good. All right, Teresa, it's now actually your turn to talk.
Thank you. And I just want to say thank you for having me today. I really appreciate it. I'm just going to talk a little entrepreneurial. I started in 1991. I was hired by 5 men, all of whom were at least 30 years older than me. There was no technology in that office whatsoever, so not even a scheduler. So I begged and begged, and we finally got terminals, and we had our schedule on the computer, and we could actually, manipulate our schedule. So it was time for me to go, and after 3 children and working a couple other businesses, I decided to just start my own. And I've had a nurse practitioner for over 20 years, so I have had the luxury of being able to retain her, but we work really well together. So in 2007, I went on a Thursday with paper charts everywhere, all those offices with the paper everywhere. I went right to an EMR on Monday. And I have 2 brothers in computer science, so they came in and we worked. I think I slept in that space Friday, Saturday, and Sunday, so I was up and running. I was not going to miss a day of seeing patients, and I saw patients on Monday morning at 8 a.m. Was it a struggle? Yes. Was I kind of disoriented on how to do it all? Yes. The patients were great, but I had a wireless system in all the rooms. And my very high-tech patient said, "You know what, Doc, I can see in your rooms on my thing." I said, "Oh, shut that down." So immediately had to shut that down and hardwire everything. So these are all just kind of these tech things I didn't know and had to learn. And so started using my EMR, started with my practice, and then as I've grown in my system, and mine is a very tiny chart called Amazing Charts, which is mainly for primary care. Not a lot of primary cares have it. There's no interoperability with Epic and all these big systems, so that's been a bit of a challenge, but the chart the company that owns this particular medical record has grown, and now I can have labs drop in, and I can do relationships with the people I use, like the big LabCorp. It drops into the chart. So these things have I loved? Yes, I have absolutely loved all of this tech. What I love the most, click, I've sent your prescription to any pharmacy in the entire country. Okay, I love that more than anything. That is my favorite feature, e-prescribing. No more scribbling out 17 million prescriptions. And if I screw up, I can fix it, or because in the other practice, you called or you wrote it all out. So that saved worlds of time. I truly believe in having eye contact with your patient. So for me, that was a challenge on how I set the rooms up. So I made sure that the exam room was where I could see the patient. So when I had to type, which I really hated typing in front of the patient, I hate it, but I have to do it or I can't get my documentation or I can't get paid. So I look at the patient and I really try to listen to them, and then I might type something and then I look at them, and one of my senior patients, who's about 85, she said, "Doc, how are you able to make eye contact and talk to me, and I really feel like you're listening to me, when all the other docs just type away?" I said, "Well, I practice that skill." I said, "I try to look at you. I get information when I see how you answer my question," which goes to what you were talking about skill in our profession and art. So if they wince when you say something, and that could be very telling, and you're missing that if your back's to them and you're typing. So I had to learn that, and I think that I'm not great at it, but I try really hard to actually look at the patient and type. As far as not storing any paper charts, oh, that's been fabulous. I don't have to worry about any of that. And so printing forms, assessments, like there's mental health assessments, it's all incorporated. And every time you upgrade your chart, you get more things you can do that they try to offload, which is great in technology. But I'm going to take a little different take on all the benefits of technology. Those things I love. Some things I really don't love. And the things I don't love about it are, well, for instance, I was at the Washington State Association running some committee, and we had to upgrade, and I told my nurse practitioner, let's do it on a Friday, so when I come back on Monday, it'll all be done. So she texts me, and she says, the server's crashed. Great, no access to any chart on Monday with a complete, patients, 20 patients to see. So I said, no problem, don't worry about it. I will just type, I know it in my mind, I know how the chart looks, no, I'll just type some up, I'll go in there, I'll type them all up, the guy will come in and fix it by 11 or 12, it'll be fine, it'll take me a little longer, I'll get them all in. Did all that, was fine. I didn't miss a beat, I just went right on. That night we had a King County Medical Society meeting, I have my medical student over here. I said, hey, what would happen to you if your computer crashed? He said, what? Okay, I was so frightened that I have been so terrified by that answer since that day. And I was thinking, this new generation of docs isn't like us. I mean, maybe you guys are younger, but I still can do it both ways. I can do it without the chart, I can do it with the chart. Doesn't really matter to me. I don't think my care is affected either way. And I looked at him and I said, if you can't, with your stethoscope and your otoscope, and you listening and talking to the patient, figure out what's wrong with that patient, then you need to go get some other kind of training. So I'm advocating for no tech training somewhere along the way in residency. I think all of them should go to rural medicine where there's no lab, no x-ray, and you better retain the art of medicine and what you've learned and apply it when you've asked the patient a question. Yes, I love tech on many levels, but that scared me, and I thought about even the robotic surgery scared me a little bit because I thought about, what if it crashes in the middle of that? Does the surgeon actually know how to do surgery? You know, I mean, those things just frighten me.
I will reassure you that the robot is not performing the surgery.
Okay.
The surgeon is performing the surgery.
So I was excited to ask you that when I came today.
That's hilarious.
So I think tech's great, but I think you need to retain the art of actually talking to the patient, looking at the patient, putting your stethoscope on the patient, and understanding what you need to do for the patient in that moment. Thank you.
Wow, that was a lot. So I want to take one of the questions from the group, and it was related to chronic conditions within primary care. So this is an opportunity for you to actually get to know the patient a whole lot, and maybe not rely on the medical record and the software quite so much. What are some innovations that you have seen there that you'd like to see there, tech or non-tech?
I would answer that by saying, what you asked about retaining patients and all of that, and I think this kind of speaks to that. I always say we answer the phone and we know your name, and we don't have an automatic phone system, and we actually know the patients, and I think that is just the number one way, and I'm sure you'll agree. If you know who the patient is, you know their family. I know everybody. I have private practice. I know their kids. I know their grandparents. When they come in from another country, I see the mother, and I know what's going on. And I think, well, I'll just give you a really quick example. There was a patient came in, she has really bad asthma. She went and saw the asthma doctor 2 days before. He said she had asthma. She came to see me 2 days later. She said, and she's sick, and she said, I just can't breathe, doctor. And I've known her for like 10 years, and I just looked at her. I said, this is not your asthma, is it? And she said, I don't think so. I said, you know what? I'm just worried you have a pulmonary embolus. I'm going to send you to the hospital. Okay, that was a whole nother to-do. I never experienced this. The ambulance driver refused to take her. So I had to call a cab and send her over there because I just knew something was wrong. I don't have any reason to say why I knew that. I just know her. Sent her over there. She had lymphoma, and it was squeezing in her chest. So I called the allergist. I said, just FYI, she had lymphoma. It wasn't asthma. But these things aren't, this isn't tech. I mean, this is hard to know. Obviously, they can make the diagnosis with the CT scan, which is great, and they could do one quickly in the ER. Those things are just chronic patients that you know when they're not right, when they're stepping out of their comfort zone. You just kind of know that. And you could see somebody's coming in with this acute abdominal pain. It's not okay. Versus somebody who, I heard over here. It's hard and it's difficult at times, but I think that's why we call it, an art and a profession.
Well, and someone may not be able to afford a CT. They may not even go to the doctor. So I'm wondering what innovations you would like to see for people of low socioeconomic status. It takes a minute.
Yeah, I'll take an indirect answer to that. So people of low socioeconomic status, a good proportion of them get their care at safety net providers, right? Community clinics, things like that. So to the degree that technology can be made affordable so that those care settings can take advantage of some of the technology we're talking about, then that will benefit those patients.
Perfect. Okay, so we now have a few minutes to take questions from the audience. I'll hand over the mic here.
Thank you. Here we go.
Hi, Josh Grins with the King County Medical Society. I work for her. One of the things I'm specifically interested in having come about, we see the evolution of the system selling to United Healthcare, for example, Polyclinic, which was a physician-based organization. We have tremendous innovation, tremendous entrepreneurialism, yet the reality of cost, constraints, limitations, how does a system integrate innovation when they're being told to cut back on paying for IV bags or whatever it may be, and as care transformation goes on to limit costs, how do you bring in, innovation into a system when the entrepreneurs want to make money at the same time the systems don't want to spend money?
Having done this a few times, I think you have to make a case that whatever your invention is or whatever the system you want to bring in will save money in the end. You have to prove it somehow or no one is going to fund it. They're just not. And then you have to find out, like I said, I went around the insurers because I knew at that time they would never even consider paying for obesity, so I went to who had the money. And I think in those cases it was the self-insureds. So those big companies pay for their own health care. They'll pay for those kinds of things. I put an on-site, I created a check your blood pressure, check your sugar, check your lipids, do your BMI, all on site at the same high-tech company, which has asked me not to say their name. And I screened all those people who never go to the doctor because they're working 5,000 million hours, a week at that company. And they did it for the last 15 years. And so if you could prove, and they had to pay somebody to come perform that. But if they could save one diabetic or one hypertensive or one heart attack, it was worth it to them.
Just want to add a little bit. So I remember years ago, managed care was coming out. I gave a lecture in West Virginia, and I had a question. The question was, well, what does the managed care think about this and that? And what the audience there didn't realize is managed care is a bunch of different models, right? Not just one model. And I was thinking about that when you said about health systems. It really, and I think I mentioned this earlier, but it comes back to the specific health system, how much financial risk is that health system? And as you said, self-insured or who said financial risk? And that's where you have to line up the incentives. And I also, so that's a lesson I think for entrepreneurs is that when you go out and you test your idea, make sure you're testing it with people who are really at risk as opposed to providers who aren't at risk. Because you'll get two different answers. One group is going to find it's not a pain point, and the other group, yeah, you're helping them.
We're running a little behind, folks, so we have time for one more question. There's a burning question here in the audience. Just raise your hand. Yes, sir. Coming all the way around.
my name is Tom Otta from Peer Consulting, and I'm really more directed this question at Cheryl and her practice, who's focused on Medicare patients, right, geriatric patients, and really more from a cost perspective. How are you able to, quite frankly, afford the multiple services and supportive services you are at, given the ridiculously low reimbursement rate that CMS provides for primary care specifically?
So we work with Humana Medicare Advantage. I think it really comes down to the care that we give. So it's knowing people. It is, we don't limit care. So I don't think of when I'm seeing somebody like I'm not going to give them something because there's risk. It's really just about closely managing and keeping an eye on. And we really do promote sort of prevention and health and patient activation. So our clinic is really like a senior center, community center. We have education all the time. We have, we teach people how to cook. We have exercise classes. We probably have 2 to 4 exercise classes in our space on a daily basis. We have a behavioral health specialist who is there at the point of care so that we are. So I guess when you say, do we get paid for that? We pay our behavioral health specialist. I don't think it's necessarily, so we're getting paid per month per patient. So it's not every service that we do that we get paid for. And so this is where sort of integration pays for itself. So a good example would be referral rates to orthopedists. We know that in our Washington market, our referral rate to orthopedists for knee replacement surgeries is significantly lower than the standard of care in this community. And it's curious. We weren't trying to do anything different, but I think as we start to look at and understand it as our own system, is what is that about? And that is about offering alternative options, talking to people about the realistic, surgery and what that means and what it's going to do, and finding ways for them to better take care of themselves. So helping them lose weight, but supporting them to do it, not just sitting in the office and saying, lose weight, good luck. It's they meet with a health coach, and we've had patients lose 50, 100 pounds. I mean, it is astounding what a team that supports somebody can actually do. And so I think when we think about cost, it's actually moving the needle on on preventing disease. It's not just treating the disease that people have, it's preventing diseases in people. So, we have people losing weight, and we have people, I take people off of diabetes medications because we get them to lose weight and keep it off. We are able to help people quit smoking, and then on top of that, it's having a way to organize in an organized, systematic way, have people do preventive measures like going and getting a colon cancer screening test before they've got stage 4 colon cancer, things like that.
Absolutely. Food and lifestyle are medicine. So we just have 1 or 2 minutes left. I want to do a lightning round. Are you ready for this? Get the mics ready. So if cost were not an issue, right, what would be one high priority need that you would love to solve right now for all of the entrepreneurs in the audience?
I could start because I have one in mind, which is right now, I think people don't appreciate just how frustrating it is for many providers to use electronic healthcare records at this point. So if you could make them more user-friendly, that would be a big deal.
I would say a health-wide database for immunizations for all of us, as we're working on that now at King County, because we're on multiple staffs at multiple hospitals, and we constantly put one set of data into this hospital and none of them talk.
I still have my yellow card.
So do I.
I definitely, for me, that definitely has to do with interoperability. I mean, I think that, you know, we're all working in our silos, and there are tremendous challenges to providing optimal care for patients because we don't have access to somebody else's information, or the patient lands in the emergency room and they're starting from scratch because they don't know what the primary care provider did. So solving that would be amazing.
Yeah, I would echo that.
Great. Well, please thank our panel. All right. Well, I want to thank everyone for coming, and I think we're going to be around for just a few more minutes. If anyone wants to talk to our panelists, ask more questions that you didn't quite make it through with Poll Everywhere, and thank you all for coming today.